Hello and welcome. We are here at the San Antonio Update in Zurich 2013. My name is Daniel Helbling. I'm a medical oncologist. Next to me stands Dr. Christoph Tausch from the breast clinic here in Zurich. He's a very experienced breast surgeon, and he tells me now some news or latest findings of the San Antonio Breast Cancer Conference in December in San Antonio. So Christoph, I think there was some data on an educational session, I think it was, about the pre-operative MRI. Which patients do benefit from this? And do we have to do this routinely now in every patient, the pre-operative MRI?
There is a trend to do more pre-operative MRI routinely, yeah? And there are streams against it. Yeah? Okay. And this educational session lecture was against it because they asked, what does it help? Yeah? Mm-hmm. And at the beginning he explained that breast cancer is a multicentric disease. We know it. And
so many spots in the breast.
Many spots are often seen. Mm-hmm. One main spot, but some satellites. Yeah, yes. And MRI can show us these spots. But the question is whether it helps if we know that and if we react to it. Yeah? Okay. So the two questions were then, can we reduce reoperation rate by MRI? And the other thing is, can we reduce local recurrence by MRI? And both questions were negated, because the trials, randomized prospective trials and retrospective trials, couldn't show that by MRI reoperation rate and local recurrence is reduced. And therefore it was the conclusion, routinely done, it is not necessary. And so in the opposite side, it can do induces anxiety, it comes to a delay of the operation, and therefore it is not recommended.
Okay, so it's probably an issue for many patients because they think, I'd like to know where my breast cancer all over is, and then they stress to have one. But it's important to give them the information that for the treatment, for prognosis and local recurrence rate, you do not benefit because we anyhow know the main spot. If I got you right, we know the main spot, we'll take that out, and the other ones are treated by the additional therapies which come later on anyhow.
That's the most important thing. We know that we need radiotherapy and we need additional systemic therapy, and by these therapies we can eliminate these additional spots.
Okay, so now I'm curious to know, here at the tumor board of the Breast Clinic, when do you actually recommend, or when do you want to request an MRI preoperatively? Are there some special situations where you think it's really useful?
Our radiologists have another opinion, but we will discuss these results now, and then I think we will change our guidelines.
Okay, but
there are special situations, very dense breast, very dense breast, very young people, but it's very difficult then to differentiate in which situation we have to do then the preoperative MRI.
So there's probably a lengthy discussion each time in the diagnostic conference.
We will see. We will see what the future will bring.
Okay.
But it was very interesting, and for my mind, it changes our policy.
Okay, that you will do done less.
Yeah.
Now after this.
Yes.
Okay.
I'm sure. Yeah.
Okay. It's okay. Good. Interesting to know. Then there was another trial, which was a meta-analysis of the CTNeoBC trial. It's something about neoadjuvant chemotherapy, especially who benefits from trastuzumab. So you thought these were really interesting, these findings. In which respect do you think it's important to know that?
It's important to know the patient groups, the different patient groups, which patients benefit from pre-operative chemotherapy, where we can expect a high PCR rate, and we have known it from different trials, but it was now confirmed by a large meta-analysis about 13,000 patients, and so we see that the more aggressive tumors,
the higher the PCR.
The higher the PCR, yeah.
Okay.
And we see it's unless of the definition of PCR. They all benefit of the PCR, and there's no difference than in disease-free survival and overall survival.
So there are different definitions for PCR, but those do not really matter. It's important. These fine distinctions of PCR definitions do not really matter. It's important that they have a PCR.
They have a PCR for the invasive tumor cells in the breast. That's the most important thing. I think, yeah. Okay.
So, and yeah, that's important that they have the PCR, and you also think that the aggressive tumors, you said, they are benefiting most, and like the triple negative, I guess, they
triple
are
negative. About 1/3 have a PCR in the group of triple negative tumors, and HER2 positive tumors and hormone receptor negative tumors with trastuzumab, with additional trastuzumab, benefit about 50%.
So those are the best.
Those are the best.
With trastuzumab and ER negative.
The luminal A subtype, clinical luminal A subtype, HER2 negative and hormone receptor positive have not good PCR rates. Yeah. So we see that they don't need a preoperative chemotherapy. Exception is when there are large tumors, so they can have a reduction, but we don't achieve the PCR.
Okay, so but the prognosis of those tumors is in general better, but
it's
still
better.
They don't achieve PCR, so which is a little bit contradictory.
Yeah,
because
that's because I think there are patients who don't benefit, and it may be that they have a disadvantage by the delay of surgery. When they don't have this, when they don't achieve PCR rate. So we don't know exactly why it is there. Okay,
so you think that's a difficult thing to think about, because one would expect that they have a better prognosis. But still, I see that some do have a better PCR rate. This is for me a little bit obvious that the aggressive tumors, the ER-PR negative, HER2 positive tumors are good, and triple negative are good. And those luminal A, which I think have a good prognosis, they might not benefit from neoadjuvant therapy, and they might have a delay.
So we don't know whether they have a benefit from post-operative chemotherapy.
Yeah, of course, yes. Yeah. Okay, good, interesting to know. Then there was a whole discussion about the Sentinel lymph node biopsy. So for me, I'm not a surgeon, but I think, the Sentinel lymph nodes biopsies are done to preserve the axilla, that they don't have so aggressive axillary clearance. And now there's some data about the benefit or the importance of this sentinel lymph node biopsy in the neoadjuvant setting. So when you do chemotherapy, so how is it actually done? You have a patient here who has breast cancer. She receives a neoadjuvant chemotherapy. Do you do the sentinel node before that? Or?
We do it before. For these patients where we don't have a clinical or ultrasound seen nodal infiltration. So we do it before. And if there is then negative sentinel node, they don't need any axillary surgery at the moment of the breast surgery after the preoperative chemotherapy. So they have these patients have an advantage by this, because we know the original status, and it's not necessary then to do radiotherapy because of lymph node infiltration. It's more difficult for the patients who have clinical signs of
a positive
lymph nodes, or we have a puncture and see tumor cells before the
chemo
period of chemotherapy, because we know these would be the patients who can benefit from the downstaging in the axilla by the preoperative chemotherapy. But we know from different trials now that these patients have an elevated false negative rate when we do the sentinel biopsy after the preoperative chemotherapy.
Okay.
And therefore, this is the discussion. Yeah? Mamonas, who presented this educational session, he is a proponent for the the sentinel biopsy after the preoperative chemotherapy, and there are several trials, posters and trials from the ACOSOC Z1071. They showed us when we do sentinel biopsy in patients who were presented with nodal positive tumors at the beginning, that we have not these low false negative rates below 10% as we expect for a good occurrence. Yeah?
Okay, so in those patients, it's easy if they have no nodes with the sentinel, but if they are positive, then they get the chemotherapy and they become negative, and then they are still removed because they were positive.
40% of patients have a downstaging of the axillary status, but we don't know it when we only do after the sentinel, because we don't know if we have a false negative or not, because we have then false negative rates about 12 to 20%.
Okay, so that's your reason to do it before.
Yes.
Yeah, but if they are
in some patients, I do it afterwards too, when I see there is a good response in the tumor.
Okay.
When we have a PCR rate and we don't see any lymph nodes by ultrasound. In these patients, I do it sometimes with a sampling of the nodes around the sentinel. Yeah?
Okay, and if they're all negative, you don't clear the axilla?
Yes.
Okay,
but
you know that there are some of false positivity is high and you might be wrong?
Yeah.
Okay, but the likelihood is small?
Yeah.
Okay, that seems to me a pragmatic, for a non-surgeon, a pragmatic approach.
It's a pragmatic approach, but it's not scientific. Yeah.
Okay.
Yeah.
So how is it done on the world? What do you think is your
very
approach?
Different. There are many institutions who do it after preoperative chemotherapy, and there are many institutions in Europe who does it before. Yeah.
Okay,
yeah.
so
it's very different. Yeah.
There's a transatlantic split, or
yes, I would say, yeah, because there's good experience from the MD Anderson. They have low false negative rates in about 500 patients, and they are proponents for the sentinel biopsy after chemotherapy. So it's a split, yeah.
Okay, good, thank you, very interesting. Make a short break.